Hi, everyone. We're going to get started. Thank you so much for joining us today for today's presentation of Positive Sexual Health Conversations with Our Youth, presented by the Morris County Continuum of Care Community Assistance Services and Youth Advocate Committees, in partnership with Morristown Medical Center and Atlantic Health. So thank you so much, Allison, for joining us today. Today's topic discusses sex, which is one of the biggest topics in the minds of adolescents and young adults, but it's also one of the topics that caseworkers struggle to discuss the most. In this training, we will remove the elephant from the room by increasing your confidence in talking about sexual health concerns. You will learn about the importance of sexual health for adolescents and young adults, and how to engage youth in conversations about sexual health topics, sexually transmitted infections, issues of stigma, trauma, and consent, sexual risk reduction, and more. And I'm sure that this is a topic that we could all appreciate some support with, how to have these tough conversations, because they are so important and they do affect everyone. So before I get into our introductions, just some very quick housekeeping notes. Everybody will be muted during today's presentation, and there will be a question and answer session at the end. So I will moderate that from the chat box, and we can also unmute people so it can be more discussion based. So just sit tight until the end, save your questions, and we will make sure that we address all of them. And if there's any question that you have that maybe you don't want to share with the group, or you need more information maybe from Allison, our presenter, directly, please feel free to send your contact information to me in a private message or to Allison, and we will follow up with you and make sure that your questions are addressed. And I will also share a link later in the presentation so you can go to the Youth Advocate Committee webpage and the CAS webpage. There you can view a recording of this webinar and find out how to get involved more if you're not already a member of one of our committees. So without further ado, my name is Becca Butts. I'm the Director of Outreach Programs at Family Promise of Morris County and the Training Coordinator for the Morris County Community Assistance Services Committee, better known as CAS. CAS is a subcommittee of the Morris County Continuum of Care, or COC, whose goal is to end homelessness in our community. The Youth Advocate Committee, chaired by Jennifer Amaya of Visions and Pathways, is the CAS subcommittee focused on addressing the specialized needs of youth experiencing homelessness and housing insecurity. Presenting today is Allison Delcalzo-Berens, who is also our CAS committee chair. Allison is a prevention counselor in the HIV Counseling and Testing Department of Morristown Medical Center. Allison worked in the field of HIV care and treatment from 2012 until 2016, when she shifted to the field of HIV and STI prevention. Allison holds a master's degree from Drew University and a certification in HIV counseling from the New Jersey Department of Health. Her primary role is to complete HIV testing activities, provide risk reduction counseling, facilitate PrEP services, and transition newly diagnosed HIV-positive patients into care and treatment services. She provides community education, outreach services, and HIV testing in the field throughout Morris and Sussex counties. Allison has acted as the chair of the Tri-County Morris, Sussex, and Warren HIV Advisory Committee since 2012. She sits on the Newark the Planning Council Comprehensive Planning Committee and attends regular meetings of the New Jersey HIV Planning Group. She also is in her second year as vice chair of the Morris County Continuum of Care and has acted as chair of the county's Community Assistance Services Committee since 2018. So without need for further explanation, we know that Allison is a great person to have for this topic. And I'd like to thank her and Jennifer, as well as the committee members, for bringing us today's program. I know that there's going to be a lot of valuable information and discussion to follow. So I can turn over the program to Allison whenever you are ready. And thank you, Allison.
Thank you for the introduction, Becca. So I'm just going to get right into it because I obviously have a lot to say at all times and trying to restrict how much I do say, so in terms of time. So today I split the presentation into two parts. The first part is an introduction with some definitions and things like that. We're going to talk about barriers to positive sexual health outcomes, get into the specifics of how to conduct a sexual health interview. In part 2, I'm going to go over STIs. We're going to talk about risk reduction and consent. I will be using a poll everywhere today. So if you take a moment to please open a browser on your phone or computer and use the web address pollev.com/MorrisCast798. I believe Becca's going to put that link in the chat box for you as well. But again, that link is pollev.com/MorrisCast798. So we'll get to that in 1 minute while you guys are working on that. I'm going to start by issuing a warning. I'm going to use words and phrases that sometimes make people feel uncomfortable. I will also be talking briefly about sexual trauma, although not in great depth. I'm going to challenge you to think openly and critically about something that can be difficult to think about or talk about with others. As we go through the presentation, please put your self-care first. If you feel like you need to jump off the call or walk away for a minute, please do so. But also remember that when you talk about sex with your clients, your success depends on your ability to present as if you're able to talk about sexual topics without shame. So that is going to be one of the main goals today, is to really develop that sense of confidence when talking about sexual topics, sexual health topics. So in order to start off the conversation, I would like us to do a small exercise. In this exercise, it is, there's no need to speak. There's no need to enter anything into the chat box. It's totally anonymous. No one can see you. No one can read your thoughts. I want you to close your eyes and think back to when you were an adolescent, a teenager, a young adult. Really, when we talk about the age group, we're really talking about like ages 12, 13 to, 23, 24 years old, early 20s. On a scale from 1 to 10, with 1 being never and 10 being constantly, how frequently did you think about sexual themes? So some examples of sexual themes, and this is obviously an endless list, but here's some thoughts. Your changing body, your sexual desires, the bodies of people you find attractive, birth control, your first time, things like that. So I just want you to settle on your number. 1 is I never thought about those things. 10 is I thought about those things all the time when I was that age. And now I'd like you to go to your browser that you put the poll EV on and just put a pin in the number that you settled on. Again, nobody can see. These are just for, just to kind of gauge where we are as a group and try to frame the conversation. I'm just going to give you another minute to put your pin in your number. And it could be a half number. It could be 7.5 if you want. So it's about, it's a few people have put in, and that's okay. Again, we don't have to put this in the chat box. This is not for everybody to know. But I want you to notice that we settled in the 70 to 100% range of how often we were thinking about sex when we were that age. So let's do the next part of this. Now think about how frequently a trusted adult, and example of trusted adults are parents or guardians, family members, guidance counselors, a pediatrician or a nurse, talk to you honestly and non-judgmentally about any of the sexual themes that you were thinking about in the last part. So here's some example of honest and non-judgmental conversations. An adult validating concerns about your body image. An adult giving you factual information about STIs, not just showing you horrible pictures of deformed genitals, but just having really factual conversations. Discussing birth control with you or STI risk reduction methods. Talking to you about your understanding of your sexuality and who you are as a person. So I want you to get that number again. On a scale from 1 to 10 being no one ever talked to you about these things, to 10 being you had frequent conversations with a trusted adult. I want to think about where you land here. And we're going to do the same thing. We're going to go to the poll EV and just put a pin where you land here of how often you had a conversation with a trusted adult. I'm going to just give you another minute. So somebody was really lucky and had, and a couple of people were really lucky and had a trusted adult that they could go to and would talk to them about these conversations. I would say that the majority of youth in that age group, you know, the 12, 13 to 23, 24, have not had a consistent person that they felt safe going to about these types of conversations. So with that in mind, you know, again, this is about framing the conversation, really thinking about what it was like to be that age and what it's like for kids now when things are even more complicated than ever, about navigating their sexual health. So that's the why did we do that? Sorry, why did we do that? Okay, so let's get into it. So I want to start with the definition of sexual health. So this is from the American Sexual Health Association. There is one of those. They define it very simply: the ability to embrace and enjoy our sexuality throughout our lives. It is an important part of our physical and emotional health. And, you know, I want to concentrate on throughout our lives, like sexuality changes, you know, from, you know, the time that we enter puberty throughout until, you know, really until our last days. That changes throughout our lives. And we want to be able to have a holistic view of sexual health that allows us to embrace it throughout that time period. So a little bit more. So the WHO says this: the sexual health is fundamental to the overall health and well-being of individuals, couples, and families, and to the social and economic development of communities and countries. Sexual health, when viewed affirmatively, requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. I just really love that because, you know, one of my pet peeves is about sexual health is that many providers, many individuals do not see this as a primary component of health. And what the WHO is saying is not only is it a primary component, but it really affects so much of what happens in the world. So it's really important. Now, here is a cool poster from the WHO on youth specifically. Comprehensive sexuality education empowers young people to take informed decisions about their sexuality and relationships in a way that protects their health. It really is about looking at the whole person and health. So sexual health is about understanding that sexuality is a natural part of life and involves more than sexual behavior. It's about recognizing and respecting the sexual rights we share and respecting the decisions of others and the decisions they make about their body and their sexuality. It's about taking responsibility for your body, your health, your partner's health, and your decisions about sex. It's about having access to education, information, healthcare, and supportive services that can ensure a well-rounded sexual health profile. It's about making an effort to prevent unintended pregnancies and STIs and seek care and treatment when needed. It's about being able to experience sexual pleasure, satisfaction, and intimacy where desired. And it's about being able to communicate about sexual health with others, including sexual partners and healthcare providers. So this is a fun graphic that from the Trans Student Educational Resources. And this is not a presentation on LGBTQ. However, if we don't talk about it, we're doing a disservice to ourselves. So we're going to go through this quickly. So gender identity at the top there is about how you identify regardless of your biology or anatomy. Your gender expression is how you present yourself in the world. Your sex assigned at birth is about your biology and anatomy. It's what you were born as, what they labeled you as when you were born. Physical attraction is about who you desire, and emotional attraction is about who you feel connected to. And this is not meant to be pigeonholing people, right? Like, you may be physically attracted to multiple genders, you may be emotionally attracted to multiple genders, and that's okay. What I want to say about this is this matters a lot, but it also doesn't matter at all. What I mean by that is that the labels don't really matter when it comes to sexual health. At the end of the day, what matters is, when we talk about sexual health, is behaviors. The label might be important to the person sitting in front of you. It also might not be important to the person sitting in front of you. Also, the person might not have figured out what their label is. None of that matters. What matters is that our job is to assess behaviors and make recommendations based on those behaviors in the best interests of the health of the client. So while it's important to understand LGBTQ, and I highly recommend that if you have not already done comprehensive LGBTQ training, that you do so. I do training and continue training very frequently. At least once a month, I'm in a training on this topic. And the science and the information is always changing. So there's never a time where you'll know everything about this topic. So I definitely recommend that. But our job is not to tell people who they are. And our job is not to hold people to the labels that they define themselves as. Our job is to assess behaviors and to look at those behaviors. So next, I'm going to talk about barriers to positive sexual health experiences. It is no longer appropriate to talk about healthcare, any healthcare, without addressing the topic of healthcare disparities. Increased health disparities, higher rates of STIs, poor emotional and physical health outcomes, and underutilization of healthcare services among some racial or ethnic minority groups compared to white groups, and among sexual minority populations compared to cisgender and heterosexual population exist. And they're caused by poverty, lack of access to jobs and education, lack of access to health insurance, lack of access to competent service providers, distrust of the healthcare system, and community infection rates. And when I talk about community infection rates, what I mean is that is the aggregation of specific infections in a specific community. So for instance, I'll give you an example. HIV community viral load in young Black men who have sex with men. So again, you'll notice I used men who have sex with men. That's a behavior, not a label. I'm not saying that they're gay and bisexual. I'm saying what they do is they have sex with men. So young gay and bisexual men of color have higher HIV viral loads in those communities. And the reason for this is because when people typically choose sexual partners, they have a specific pool that they're working in, right? If you are more limited in the group of people that you have access to have sex with, then the prevalence rate of a particular STI might be higher in that community. So that's what we talk about when we talk about community infection rates. I want to make sure y'all know that these disparities are not necessarily because people of color or because people who identify as LGBTQ are engaging in riskier behaviors, but instead there are social and economic factors that decrease access to healthcare and increase risk factors. So I want to be really careful. Like when I say that there's healthcare disparities, the blame is not necessarily meant to be placed on these communities. So let's talk about stigma. So I know that in each of your respective occupations, you probably deal with different types of stigma all the time. There's a lot of stigma around sex, especially for youth. So I identified a few areas related to sexual stigma for youth. So as young people are developing, menstruation is an area that can cause a lot of shame and embarrassment. Young women figuring out how to manage their menstrual cycle. After, that never happening before, right? It's very, very sudden. Sexual arousal, right? So being a young man and having an enlarged penis during gym class, right, is probably an image that we can all sort of recall, whether it was yourself or somebody in the class, right? That was probably embarrassing for that person. Early pregnancy and early parenthood, a lot of stigma around that. A lot of young people, remember we talked about labels a few minutes ago, a lot of young people are trying to figure out what their label is, how they identify, and who they're interested in. Sorry, I'm in Morristown with the busy South Street outside my window, so if you hear trucks and cars, my apologies. So body image. Again, when we talk about, developing bodies, as young people's bodies are changing, and they change throughout that whole time, right? That whole age group it's constantly changing. There's a lot of self-consciousness around that. Sex work. So I had a young man in his early 20s come to me a few weeks ago, as a matter of fact, seeking prevention services. And it took me 3 sessions with this person until we got to the root of why he was so worried. And it's because he was engaging in sex work. He was getting paid to do gay pornography. And he really struggled to use the words. And he said, it's just that people don't understand about this, and they try to talk me out of it, and I really want to do this, but and so we had to talk about that. There's a lot of stigma around that. Sexual assault. We'll go a little bit more into sexual assault in a moment, but there is a lot of blaming and questioning the victim that happens with sexual assault, especially with young people, but I think at any age. STI. So one of the things, and again, we'll talk about this a little bit later too, is about sort of this question that especially young people ask when they are finding new sexual partners, is they'll say, are you clean? Meaning, do you have a sexually transmitted infection? And at the end of the day, what we can really say about that is that's stigmatizing language. What is somebody going to say? No, I'm not clean, I'm dirty. And so, right there you have a stigmatizing language. And then performance. There is a lot of stigma around how good you are at various, sexual situations. Okay. So again, I am not going to go into depth around sexual trauma. I'm not an expert, and it's really several days of training to become even close to competent in this field. But I do want to make sure we're addressing it because it could come up, right? When you start to talk about sex in general with people, it's possible that this is something that can come up. You can trigger a trauma. So just thinking about how hard it is just to talk about sex, look at all those topics from the last slide. That is compounded when there's an assault that happens. So here's what I want to say about sex versus assault. I have actually had times where I'm sitting with a patient, we're doing a questionnaire, and I'm going through some questions, and there's a block that happens. And the block is because the person in front of me does not believe their assault was sex, that there's a definition problem here. For somebody who associates sex with consent, they can have a block when you're starting to ask them questions about whether or not they're sexually active, because they're not seeing what they did as consensual sex. They're seeing what happened to them as an assault on their body. And so when you are engaging in conversations, be curious and careful about why there's a block when you're talking to people about these topics. A person who's experienced sexual trauma must be ready to talk about it. So you can walk away from today's training and say, okay, I'm ready to talk about sex with my clients, right? And then your clients are not ready to talk about sex with you. And so if they don't want to talk about it, that's okay. Because we want to encourage freedom around conversations about sexual topics does not mean that we push others to do so when they're not ready. I also want to mention, again, a plug for extra training. There are trainings for sexual assault counselors to become a sexual assault counselor. I have been through that training, and it's intensive and it's many weeks, but it's worth it if it's something that you're interested in doing. So let's go back to the conversation about the gender unicorn. Being, I would say, having the perception that you are different can cause trauma. Also, around gender and sexuality, there might be a history of bullying. Maybe the person hasn't come out to their parents yet because their parents, they don't feel that they're going to be accepted by their parents. Maybe they did come out and they were confronted with physical or emotional abuse, which does happen in that community. So be aware that any conversation you have around gender identity or sexuality can trigger those kinds of responses, trauma responses. And lastly, there's a lot of cultural and religious baggage around sexual topics. Being aware of how these conversations can bring up issues of morality, shame, and disgust can help you as you attempt to navigate the conversations with your clients. So just some things to look out for. There are some common effects of youth sexual trauma. So sexual trauma can manifest as mental health conditions. So some of the common ones are PTSD, depression and anxiety, sleep problems, mood problems, eating problems, substance use problems. They can manifest in physical symptoms. For instance, gastrointestinal disorders, like just think about how often young people have stomach aches, right? That's really like anxiety a lot of times, but also it can become something more insidious. Headaches and obesity, as a matter of fact. And then of course, obesity leads to other things like diabetes and cardiovascular problems. Sexual trauma can also manifest in behavioral or social symptoms. So for instance, hyper or hyposexuality. If somebody is having more sex than you would assume is natural for a young person to have, perhaps that's just their them being their normal selves, but it also could be indicative of a sexual trauma in the past. Also, troubles at school, troubles with being social in social situations, things like that also can exhibit. So let's get to some more specifics, and how are you going to incorporate sexual health screenings or questions in your assessment tools, right? So that's really where we do all of our legwork, right? Is during our intake paperwork, when we're sitting down, when we're working with the client one-on-one, we're learning about them. I imagine that most of your assessment tools include questions around mental health and physical health. Are they encompassing questions about sexual health? But wait, how do you even talk about sex, right? So it's not just about what questions do you ask, it's also about so I have like a do and don'ts list. So first of all, do be yourself. I'm going to admit something to you. I am not cool. I wasn't even cool when I was a teenager. Like I have never been cool. For me to pretend like I am cool right now with a young person would not be authentic, it would not be genuine, and let's face it, youth see right through you when you're not being yourself. So it's okay to be kind of awkward, which is what I am, and just be yourself. And I will tell you that I have had people relate to me much more than they thought they would. You know, I'm sort of like, you know, I'm short, but I certainly don't look too young. And, you know, my primary population that I serve are young men who have sex with men. To be honest, you know, like I do not look like them. But I have had them, every single one, tell me, wow, I didn't expect to have this kind of conversation with you today. I'm so glad I'm here. And so, and that is not me being overconfident. That is me knowing that I can make an impact just by being myself. So don't feel like you need to be somebody different. I would definitely look in Urban Dictionary and learn some of the terms that young people might use when they're talking about these topics, but certainly you don't necessarily have to use them yourself if you're not, you know, if that's just not who you are, right? So the next piece of that is do not overshare, right? You can be yourself, but don't talk about your own sex life, right? And so, you know, don't talk about it. I feel like these are pretty basic tenets. You know, there's no reason to talk about your identity. Sometimes there are times, like if you do identify with a certain population, it's okay for you to say, you know, I understand where you are, you know, I've been, in my experience, you know, like I'll say, like I've been a young woman before I get it, or, you know, something like that. But, you know, it's not necessary for you to talk about any intimate details of your own life. Do be open. So when I say open, I mean project a non-judgmental expression. When you're talking to people, be really, you know, I have one of those faces that is like an open book face, where if I'm surprised, you know, I might, you know, and so really school your features. Try not to, and honestly, nothing surprises me anymore after doing this for a number of years. There's almost nothing that can surprise me anymore. But definitely don't show it if you are surprised. You know, really work on schooling those features. And that goes along with don't project your own feelings around sex to your clients. I made a statement at the beginning when I did my trigger warning where I said something like, you need to be able to demonstrate that you are not feeling ashamed of talking about sex. I don't necessarily mean that you actually don't feel uncomfortable sometimes. Like, you can feel uncomfortable, I don't care. Don't show that to your clients. Do be curious, right? Ask questions, and you know, seek to find out more about why they are feeling a certain way about sex. Don't ask unnecessary questions. So I would imagine that for most of you, you do not need to know if the transgender male in front of you has a penis or not. You probably don't need to know that. If you do need to know, then, you know, certainly, you know, ask it, you know, if it's relevant to the work you're doing with them. But let's be really clear about what you actually need to know, versus what you want to know, versus what is helpful to the client. Be matter of fact. And again, this kind of goes back to being open, but in a little bit of a different way. You want to have a non-judgmental expression, but you also want to have non-judgment around terms you use, and the way that you talk about sex. Don't make assumptions. So for instance, if a young person comes into your office presenting as male but wearing makeup, don't assume that that person is transgender. You would be doing a disservice to your client, you know. So again, it's about asking, how do you identify? Not saying, oh, you know, you must be identifying as female. Use proper names for body parts. So this is something that I prefer to do. as much as possible. There are times where I will have to adjust my language to match what the client's understanding is, especially for young people. They might not always have an understanding of like what a cervix is, right? So, so there might be, but it's part of the education piece is to lead by example and not have shame around using the correct terms for things. Don't be rigid, right? So, for instance, one of the things about, having projecting a non-judgmental expression is trying to use eye contact as much as possible. But if someone's not using eye contact, they don't want to maintain that eye contact, give them something to do with their hands so that they're not feeling so self-conscious about the fact that they're not looking at you, right? Again, with all the stigma and shame around sex, if you're using words like penis and vagina and they're just not there, give them something to do to sort of distract them from that. If they're struggling with a particular topic, maybe you do want to get your assessment tool filled out, but definitely redirect to something else if they're starting to feel nervous. Do refer. Don't assume you know everything, and don't assume that you can fill all of the roles of a sexual health counselor. It's can be tricky work. So definitely refer out. Don't push, right? So if you refer somebody to a provider for an STI testing, and they don't go, right? Like they just might not be ready. And so, we do a lot of that with HIV. Like it's not, HIV can be really scary for people. So people really have to be ready for something like that. Do seek more training. I think I've said a couple of times, there's a few different types of trainings that I would recommend that you get in addition to this training. Don't be a parent. And by this, I mean, don't contradict their parents' wishes, number one. And number two, don't try to assume the role of someone who knows everything. They already have a parent that does that. Or, usually. So in their opinion, right? From their perspective. Okay, I'm gonna move on. So let's just go with some basic questions. And so when we, so these are questions that obviously I have a lot more questions on my questionnaire, but these are things that I thought, are ideas for things that you could incorporate. Again, it depends on what you need to know. As we go through on the sample questions, understand that they may or may not be important for your purposes. And so you need to distinguish between what you need to know versus what you want to know versus what you think you need to know. The first one, for instance, you may not need to know what their assigned sex at birth was. It depends on the program, probably. You do need to know how they identify. We always ask that question. And sometimes we get like surprised, oh, what do you mean? Don't I look like a man to you, right? And so, people might just generally become defensive when you ask that question. But again, this goes back to not making assumptions. And so if you are making assumptions about people, there may be that 5% of people that walk into your office and wish that you had asked that question. So here's a question. Have you had sex in the last year? And you can adjust this to the last 6 months, right? To the last 3 months, whatever you think is important. But that's a quick yes or no question. And it just lifts the elephant a little bit, just moves the elephant out of the room. Have you had sex? So here's another thing you may or may not need to know. With whom, right? So for me, I need to know that because I'm assessing risk. And so when I assess risk, I need to know who the partners are. But you may not need to be assessing risk. You might just want to, you might have other purposes in mind. So for quote heterosexual individuals, the question is, what are you doing to prevent pregnancy? And I think you'll notice I did not put for young women, what are you doing to prevent pregnancy? Because both young men and young women should be thinking about that. some other questions around pregnancy, like if somebody says, nothing, I think the question can be like, well, are you looking to get pregnant, right? Like, so some people are not preventing pregnancy actively because they want to be pregnant. So, don't make assumptions that just because somebody is a young person that's not an interest of theirs, or that they're not indifferent, right? Like, oh, I don't care. Have you asked your partners about their STI status? And we're going to talk in the risk reduction section later about how to even ask your partners about STI status. What STIs have you been tested for in the last year? And this also helps to gauge your knowledge or your understanding of what their knowledge is about STIs, because STI topic is trickier than you would assume all the time. So here are some questions that you would, or the next question you might want to incorporate with your substance use questions if you have them. But this helps me to assess, again, a person's level of risk. Are there ever any times that you drink so much or get so high that you make decisions you would not make if you were sober, or that you forget what you did? And so, sometimes we'll ask people if they're using condoms and they'll say yes, but, I use them 75% of the time. We say, well, what happens the other 25% of the time? They say, well, I don't know, I was too drunk, I don't remember, right? So, so that's a common reason that people don't use barrier protection. And here's another question that, again, you may not need to know, but it depends on how you're assessing risk. Do you ever exchange sex for money, drugs, a place to stay, or for anything, right? So next we're gonna ask questions about barriers, barrier protection. So for everybody, you would ask, how frequently do you use condoms? So the question is not, do you use condoms, because that's not specific. You would ask, how frequently do you use condoms? And you can give them examples. Do you use them half the time? Do you use them all the time? I use a times out of 10 number for people, because, if they had sex 10 times, how many times did they use condoms? And, we ask questions about specific types of sex as well. Vaginal, anal, or oral sex. Again, you may not need to do that. Again, you might not need to do any of this stuff. Do you feel safe to ask your partners to use a condom? So we do have sometimes it's safe and sometimes it's confidence, right? I have found that especially young women have self-confidence issues when talking to partners about condom use. There's a fear that their partner will not want to be with them anymore. Their partner has given them excuses, and I think for young people it's hard to see when those excuses are manipulations. For instance, like, I'm too big for a condom, right? I mean, there's a condom for everybody. So, there's ways to mitigate almost every reason to not use a condom. So a lot of the work we do with young women is around just confidence around talking to partners about condoms. So what would happen if you asked your partner to use a condom, right? And sometimes there's just fear there. Like, I don't know what would happen if I asked my boyfriend to use a condom, what would he say? Sometimes just really getting them to frame, like, what would your partner actually say? Would help. Like, would they actually say no? Do you have access to condoms? So again, a large reason that people don't use condoms is because they can't afford them. Young people can't afford condoms, right? So where do you get your condoms from? And just like, shameless plug, we have condoms here for free. You can just get them there in the waiting room. What are the reasons you don't use condoms, right? So those are all questions about barrier protection. And then we had at the Family Health Center some training from JBWS a few years back, and a series of trainings on HIV and intimate partner violence. And after those trainings, we started adding safety questions to our assessments. So here are just some examples. Do you feel safe to say no to your partners if you're not comfortable or if you do not want to have sex? How does your partner react to your boundaries? And are you in any way fearful of your partner? So why do we ask these questions? So why do you ask questions in your assessment at all, right? So it's all about education and referrals. So perhaps you are planning to do some education yourself, or perhaps somebody, you find out that somebody's been having sex for the last year, but they've never had an STI test. Maybe you've learned that there's a sexual assault history, right? There are lots of providers that provide services to assist with these things. And definitely later I'll put my contact information in the chat box, because if you'd like help, expert referrals is one of our specialties. Shameless plug, as David Salzman says, shameless plug. At the Family Health Center, we can provide these services as well. We do sort of like on the road testing and risk reduction counseling. So we've gone to IOPs, we go to detox, we go to homeless shelters and drop-in centers. We go to treatment centers. We go lots of places. And also we've had a lot of youth providers bring their clients right to us. So they'll transport them to us, and we'll just spend like an hour just going through all the youth that they bring, the kids that they bring, and we'll test everybody, and we'll provide them with risk reduction counseling. Roger showed a young person how to use a condom last week. We have like a model. Like he just did not know how to use a condom. So like those are things that we do here. So if you need help, we're here to provide the support for you. So I'm gonna go into part 2. So we're going to talk about sexually transmitted infections, or STIs. Here's a fun poster. I have this one up in my office from New Jersey Department of Health. And this is an actual statistic from the Department of Health, the New Jersey Department of Health in New Jersey. 1 in 2 people will get an STD by the age of 25. So, when we talk about youth, I know for the COC's purposes, for HUD's purposes, we talk about youth are up through age 24. So we are saying that for all youth, 50% will have an STD in New Jersey by the age of 25. So STI education is important for our youth, and it's important for you to kind of get an idea of what's going on with them. So true or false, and I don't know, you can put your T or F in the chat box, or you take yourself off mute and yell it out. True or false? I would know if I have an STI because I would have symptoms. Okay, so we have a lot of falses. So this is sort of a trick question, because technically, yes, if you had symptoms, you would know if you had an STI, right? However, not all STIs show symptoms right away. And the diagnosis of a particular STI depends on testing, right? So, certainly a provider can make an assumption when you come in and say, like, it hurts when I pee, right? So, but a provider wouldn't know which STI you have. They can make an assumption. They wouldn't know just by telling them that. So how do I go forward? Okay, there we go. So I'm just going to go over, so there's 3 different types of STIs. The first I'm going to go over is viral infections. So human papillomavirus, or HPV, is the most commonly transmitted STI. HPV can be spread through oral, vaginal, or anal sex. It can be spread even when the infected partner has no signs or symptoms. HPV usually goes away on its own. It can cause genital warts, which are treatable. It can also cause cancer. And the types of cancer that HPV can cause includes throat, tongue, tonsils, the vulva, the cervix, the penis, or the anus. There is pre-treatment for these types of cancer-causing HPV, but they don't always work. There is a vaccine for HPV, the Gardasil vaccine, but that does not protect against all strains of HPV. There's multiple strains of HPV. HIV. So I have been working in the field of HIV for nearly 10 years, and probably some of you know that I could talk about HIV by itself for 2 hours. I'm not going to do that. I have condensed it into about 25 seconds. So I feel like I deserve a round of applause for that editing capability. So HIV is an immune system disorder. It affects the immune system by converting its viral RNA into your own DNA. It's spread through vaginal, oral, or anal sex, sharing injection drug equipment, and through breastfeeding. There is no cure for HIV, but medications are available to manage the viral load and decrease viral spread. There are no early symptoms of HIV except through acute HIV infection. A small percentage of people with HIV experience flu-like symptoms about 3 to 4 weeks after exposure, which go away on their own, similar to the flu. But other than that, there are no other early symptoms of HIV. Symptoms of an advanced HIV disease or AIDS usually begin about 7 years after exposure if it goes untreated. Herpes, genital herpes. There's 2 types of herpes viruses, herpes simplex type 1 and type 2. Herpes is spread through oral, vaginal, or anal sex by an infected partner, whether there is a visible sore or not. So this is a common misconception, is that if somebody does not have an active outbreak, they cannot transmit the herpes virus. Right before an outbreak, a person is infectious. Condoms may not prevent the transmission of herpes. There is no cure for herpes, but medications are available to help prevent or shorten outbreaks. Symptoms are mild and mistaken often for another skin condition like a pimple or an ingrown hair. Symptoms usually include 1 or more painful blisters around the mouth, genitals, or rectum. At the first outbreak, you might experience flu-like symptoms. You also might not. Hepatitis. So hepatitis is an inflammatory condition of the liver, usually caused by viral infection. There are 5 types of viral hepatitis, A, B, C, D, and E, the alphabet of hepatitis. But the most common are the first 3, hepatitis A, B, and C. Hepatitis B and hepatitis C are transmitted through contact with infectious body fluids, such as blood, vaginal secretions, or semen. Sharing drug equipment and having sex with a partner who is HPV or HCV positive are the most common methods of transmission. Breastfeeding can also result in transmission. Symptoms of hepatitis usually do not occur until liver damage has occurred. So usually several years down the road, once the liver has started to become damaged. There are vaccines for HAV and HBV, and there's treatments for HCV. Oh, you know what I did? I reordered my papers. Okay. So the next group of infections I want to talk about are bacterial infections. So the first is syphilis. Syphilis, and I just want to say something about syphilis. We have seen such an uptick in this county of syphilis infections, which are so preventable, and it's very disheartening over the course of the last year, 2.5 years. And yes, I actually mean during COVID, there has been an increase in syphilis infections. So syphilis is spread through direct contact with a syphilis sore during anal, vaginal, or oral sex, or to an unborn baby from an infected mother. And that's called congenital syphilis, and that is also on the rise nationally, congenital syphilis. So syphilis has 3 stages, and the first stage is called primary stage. And usually, if there are symptoms, which there are not always symptoms, there will be round, painless sores at the location that the infection entered. The sores usually last a short time and they go away on their own. Secondary syphilis infection is characterized often by skin rashes on your feet and hands. They're usually light and usually not very itchy. They're just sort of there and then they go away. Also mouth sores. You can also experience fever, swollen glands, sore throat, headaches, weight loss, fatigue, a lot of like flu-like symptoms. They eventually go away, and then latent or late stage syphilis is characterized usually by neurological impairments. So difficulty coordinating your muscle movements, paralysis or numbness, eye or vision impairments or blindness, dementia, and ultimately can result in death. Gonorrhea usually has no symptoms, to be honest with you. A lot of people go about a year without symptoms before they start to have them. So, and during that entire time, you're still infectious. You can still transmit these bacterial infections, but you're just not showing symptoms. So possible symptoms include vaginal bleeding between periods, painful urination, increased vaginal or penile discharge, itchy or sore rectum, painful bowel movements, bleeding or discharge from the rectum, painful or swollen testicles, and sore throat. Gonorrhea can be transmitted to the anus, to the eyes, the mouth, the throat, the urinary tract, or the uterus. They are curable with antibiotics, but you can be reinfected, right? So these are bacterial infections. So whereas the viral infections typically don't go away, you know, some of them can be treated, some of them can't. But with bacterial infections, you can be treated for gonorrhea and then become reinfected with gonorrhea. So a lot of times what we try to do is we encourage people to come in with their partners. And there are in New Jersey ways that a partner, if you test positive for gonorrhea, for instance, you can get an extra dose of antibiotics for your partner. Just bring it back to your partner. And that's because usually what happens is the source patient gets treated for gonorrhea or chlamydia and then goes back and sleeps with their partner and just gets it again. So that's one of the common troubles we have with gonorrhea and chlamydia. And gonorrhea can lead to serious health problems if it's untreated, which is silly because all you need is antibiotics, right? It's just so simple. Chlamydia, again, often has no symptoms. Possible symptoms include unusual discharge from the penis or the vagina. In women, discomfort when you urinate or have sex, lower abdominal pain, nausea or fever, excuse me. For men, burning when you urinate, burning or itching around your genitals. It can be transmitted to the urethra, the cervix, the rectum, or the throat. It is curable with antibiotics. Again, you can be reinfected, and it can lead to serious health problems if it's untreated. The last infection is a parasitic infection. Trichomoniasis, again, often has no symptoms. Possible symptoms include itching or irritation inside the penis, burning after urination or ejaculation, penile discharge, itching, burning, redness, or soreness of the genitals, or change in vaginal discharge. It can be transmitted to the lower genital tract in women, like the vulva, the vagina, the cervix, or urethra, and to the urethra inside the penis for men. It is curable with medication, and you can become reinfected with trichomoniasis as well. So that was a lot of fun facts. I want to stress that you can find STI fact sheets on the Department of Health website very easily. So you do not need to I should have said this in the beginning. I hope you didn't all take lots of notes or anything on that. There are fact sheets that can tell you everything you need to know. You can hand them out to your clients so that you don't have to go over all this stuff. I want to say that the thing I really want everybody to walk away with is that just because, right, it was the first true or false question, just because you're not having symptoms doesn't mean that you do not have an STI. One of the things about youth and STIs that I have found is that oftentimes they will say things like, of course I don't have an STI. Of course the person I'm sleeping with doesn't have an STI. We're young. Young people don't have those problems. And so I feel like STI education is so important because there's such a misconception that young people, just because they haven't had enough sexual partners, there's this idea that young people haven't had enough sexual partners to have an STI. And it's, as you could see from that poster from a few moments ago, that's just untrue. It's just flat untrue. 50% of young people will have an STD before the age of 25. So let's go to the next true or false question. You can put this in the chat box, true or false. If I want to check my status, my STI status, I should go ask for a, quote, STD panel. Okay, so a lot of truth. So the term STD panel is another one of my pet peeves. There is this assumption that if you go to a healthcare provider and say, I want an STD panel, that this is some kind of universal term that will give you the same outcome every time. And it's just not true. Here is how you get tested for various STDs. So we went over 8 STIs a few moments ago, 4 viral ones, 3 bacterial ones, and a parasitic infection. And they all have different ways of figuring out what whether or not you're positive. So for HPV, it requires a vaginal, rectal, or throat swab. If a man is having symptoms of HPV in their penis, a urinalysis should show the result, the positive result. However, not necessarily, and if there are no symptoms, it might not show up in a urinalysis. So usually the best way to determine is through a swab. And so for HIV, it's a rapid finger stick, a whole blood sample, or an oral swab. For herpes, it's a blood test, or to take a cell culture from an active sore and test that. For hepatitis, it's a rapid finger stick or a whole blood sample. For syphilis, it's a blood or a spinal fluid test. For gonorrhea, you can do a urinalysis, but how is a urinalysis going to tell you if you have gonorrhea in your throat or your rectum? It's about where you have sex, right? Like what parts of your body you're having sex in. Same with chlamydia, a urinalysis or a swab, and trichomoniasis is a swab or a urinalysis. So if you walk into a place and you say, I want an STD panel, and nobody asks you any questions about where you're having sex on your body, they are not going to give you a competent STI test. What we counsel our patients to do is be really specific about what their risk level is for each type of STI and ask specifically for that type of test. And I'm going to tell you something about most providers. Like most primary care providers do not have the equipment on hand to do a rectal swab. So if you have a young man who's having sex with men, or if you have a young woman who's having anal sex with men, they are at risk for HPV in their rectum, gonorrhea or chlamydia in the rectum, and no one's doing a swab there. So this is not going to be a poll, and it's not going to be a question that you put the answer to in a chat. I want you to think back to the last time any provider, any healthcare provider asked you, are you having anal sex? I want to guarantee, almost guarantee, that 98% of you just said no to yourself. Nobody's ever asked me that. So this is why we have specialized centers, specialized people to be able to ask those questions and to provide the advice that we provide. Sorry, I think I just got on my soapbox, guys. Sorry about that. It's a subject I'm very passionate about. Providers, let me tell you something. Providers, healthcare providers are people, and they're embarrassed about sex too. And they pediatricians tend to be getting better and better at this because there's a lot more focus around LGBTQ healthcare. But there's I would go to the opposite end of the spectrum and also talk about, older patients are almost never asked about their sex lives. It's just assumed they're not doing it anymore, or that they know what they're doing, and they know about their risk level, and that's a poor assumption. So let's talk about risk reduction. What is safe sex? Does anybody have you can put this in the chat. What is safe sex? You can also take yourself off mute if you like and say what you think safe sex is. Do we have anybody intrepid enough? That's okay. I guess think to yourself what you think safe sex is. Using contraceptives, no sex, using form of protection or abstaining. Okay, so good. So yes, there is no such thing as safe sex. That's called abstinence only education or risk elimination, right? It's not risk reduction, it's eliminating the risk, is to not have sex, right? which is not a practical solution for providing risk reduction counseling services to clients, especially youth. So instead, we talk about safer sex versus less safe sex, right? So everything is on a continuum of risk reduction. So here are some common risk reduction methods. Obviously, barriers are the most common. And by barriers, I mean condoms, and less common are dental dams. So a dental dam is like almost like a square-shaped condom that you lay over the vagina to engage in oral sex with a female partner. So those are barriers. U equals U is stands for undetectable versus untransmittable. This is HIV specific, but it can be sort of transferred to other infections, but mostly it's about HIV. So when a person is HIV positive and they're taking their medication on a regular basis, they become what's called undetectable, meaning there's such a small viral load that modern science cannot detect it in the bloodstream. Doesn't mean that there's no HIV, it just means that they are in undetectable status. When that happens, the virus is virtually untransmittable to another partner. So that is a huge prevention method right now, is just to get people who are positive into treatment. We have care and treatment services here at the Family Health Center, for instance, and that is one of the outcomes that we are judged on by the state and by our funding sources, is what our undetectable rate is. PrEP stands for pre-exposure prophylaxis. It is also related to HIV. It is a once-a-day medication you take if you're HIV negative, but you're in a high-risk population, to prevent HIV infection. And we do have a PrEP clinic here. That's one of the hats that I wear, is directing people through the PrEP program, and it's a medical program. The next thing is to be tested, right? So just the act of testing reduces your risk. It reduces the risk that you will get an STI, and it also reduces the risk that you will spread an STI to a partner. The last little image there are the two bubbles talking to each other with cans. Really just is about communication. It is the most underrated but most effective ways of preventing HIV and STI infection. Just the simple act of saying to a partner, when was the last time you had an STI test and an HIV test, will reduce the likelihood that you will get an HIV and any STI, because the answer tells you something. If the person says, "Oh, I got an HIV test and an STI test a year ago," that tells you something. If they tell you last week, that tells you something. If they say I've never had one, that tells you something. If they say 3 years ago, that tells you something. And it also gives you something to work off of, as like like if they say 3 years ago, you can say, "Oh, okay. How do you feel about using condoms?" Because 3 years ago is a long time. The stage of change model. So I'm not going to go too deep into this, but it is how we work on risk reduction, right? So here's an example. A patient comes in and they say, or your client comes in and says to you, "I want to use condoms, but I can't afford them." What stage of change are they in? You can put it in the chat box if you think you know. Yeah, contemplation, right? Like they want to use condoms, but they don't know, right? So your job then is to remove those barriers. And so, so that's a good example. Maybe it's more complex. Like I use condoms half the time, but sometimes I forget to bring them with me, right? So what stage of change is that? Yeah, well, it's action, really. They are using condoms. Yeah, they are using condoms, but it's just not consistent, right? And so how do we move them to more consistent usage? So again, I mean, I'm making a huge assumption here that the people in the web room today are familiar with the stage of change model, but that's mostly a lot of what we use when we're doing risk reduction counseling, how we're moving people through the stages of change. Okay, so the last topic is on consent. So this is a really fun image that from Planned Parenthood that I really love. Number one, because I love French fries, but secondly, because it's a great acronym. So consent is freely given. We need to feel free to say yes or no without pressure. If your partner isn't willing to take no for an answer, there's no consent. If the power in the relationship is not equal, then it is difficult for both partners to experience full consent. Consent is reversible. So consent's a process. Something might change your level of comfort with the experience, and it's okay to change your mind. And just because you said yes before doesn't mean you're saying yes every time, right? And so a lot of times, this is something that youth have trouble understanding is this idea that like somebody can feel comfortable with something one moment, and then quickly that changes, and that's okay. It's okay to change your mind. I think youth are so used to the idea that they're supposed to be really confident all the time that like the idea of being wishy-washy on something is like, oh no, like am I not allowed to do that? Consent is informed. So there's a couple things that we mean when we talk about being informed. First, it's about being sensible of your actions. So being underage, being under the influence of alcohol or drugs, having a cognitive impairment or a developmental disability means that you may not have the sensibility to make good choices. The second piece of that is actual information. Do you have all the information you need to make good choices? Are you aware of the risks involved in the choice you're making? Do you know when your partner was last tested for STIs? Is your partner using any method of birth control, right? Like these are all questions that you want to have answered. Consent should be enthusiastic. What we mean when we say enthusiastic is that there needs to be a firm yes. It can't be like a shrug or a lack of an answer. Disinterest does not mean yes. And consent needs to be specific. So if you say yes to oral sex, does that mean you're also saying yes to vaginal sex? If you say yes to vaginal sex, does that mean you're saying yes to vaginal sex without a condom? Right? Partners need to be clear on what sexual activities they are getting consent for. So this is the last slide, and this slide is about encouraging sex positivity. So we don't want to just be able to talk about sex with our clients. We want to be able to support them in feeling good about their choices. Sex should be a good, positive experience. And if you don't feel good about it, if your patients don't, or clients don't feel good about it, if they feel guilty, then there's something to dig up there, right? Like there's something there. If you're comfortable with your choices, whatever those choices are, then you're doing it right. And so sometimes like people will be like, oh, like I did a thing, and I'll just be like, listen, I don't care. Whatever you did, it's like not my life. It's your life. What we want to talk about is, do you feel comfortable about that choice? And if they say, no, I wish I had done it differently, then that's where we work off of, right? And I guess I'll go back to the client I was talking about earlier in the presentation who is engaging in sex work, right? Like he said, like, I enjoy myself. I want to do that. And I'm getting paid to do something I really, really like. And I just want to do it safely. And what am I going to say to that? That's wonderful. You want to do something safely and or as safe as possible, right? The more safe way. And so, that's all we can do. We do need to respect the autonomy of our clients to make their choices. And that is it. So I think I did okay, like an hour and 5 minutes or something. So I am available for questions. Becca, are you there?
I am. I was just going to say, thank you, Allison. You did great on time. And I did not get any questions in the chat. So if anybody wants to put a question in the chat or just unmute yourself and speak up, we'd be really happy to hear from you. And I am also going to put the links to the CAS webpage and the Youth Advisory Committee's webpage in the chat, so it's there for everybody to access. I'd also like to say, Allison, that I'm really impressed at how you got through all of that information in that time frame. It was really helpful.
Well, like this is a subject I'm really passionate about. So I obviously I like make my living doing this. So I could probably talk about it for a whole day. But I hope that I got all the high points. If anybody would like more in-depth training for their clients, I'm happy to do that too. Again, we offer education and outreach in conjunction with mobile testing. You know, so we're open to doing that too. I also put my information in the chat box. So if you had questions, I know this is a sensitive topic. So if you had questions, but you didn't want to share them with the whole room, I am available for that as well.
Great. And if anybody else has a question to ask, please go ahead and interrupt me. But I have a question for you, Allison. You've said that it's possible for you to come to other providers' sites. And I'm just wondering, what's the best way to get people connected? Because I agree that a lot of these questions don't always get answered by medical providers, not because that medical provider doesn't have the information. It just might be a level of comfort in asking the right questions to get the information that you really need and accurate information that's helpful. So I'm not sure, like, if someone was to be referred to you, how they would access your clinic, or if that would just be done with you visiting that specific provider.
Yeah, so I would just email me. We can do it either way. We have been doing limited outreach throughout COVID. We have obviously you know, COVID prevention methods that we put in place as well. So obviously, if that's a consideration, I know a lot of providers are not open right now, but you know, so we could do it either way. I mean, we're right in the town hall building. You know, nobody has to make an appointment. When people are under the age of 18, there's additional work that we do for them, because technically you can test for HIV through our program for free without parental consent over the age of 13 and up. But there are a lot of implications associated with an underage person becoming positive with HIV, or you know, being diagnosed with HIV. So you know, or any other STI, but HIV is a little bit more complicated. And so we do a little bit more work with people under the age of 18, but it's possible. So I would just reach out. We're really open to making anything work. I mean, I know in the past, Visions and Pathways has just brought people to us. I've also gone to Visions and Pathways, just thinking about a youth provider specifically. So we've done both for them. So, you know, like, we're really flexible. So whatever, you know, I don't know if that answered your question. Maybe I over answered your question.
That absolutely answered my question. Thank you so much. And I'm just glad that everybody on this call today is a little bit more clear about this service being available, because it's very much needed. I would say that if there are no further questions, anyone who's been holding it in and just waiting, we can probably conclude today's webinar. Is there anything you'd like to add, Allison?
No, absolutely not. Just thank you for listening.
Great. Thank you very much, everyone. Please feel free to reach out. Allison's email is in the chat, and you can also visit the CAST webpage anytime and get in touch with us. We'd love to talk to you. Have a great day.